I'm David Rowland. I'm one of the paediatric orthopaedic consultants in Glasgow. I was a registrar here in Hull. Can I have a quick show of hands? Who has a paediatric practice? Quite a few of you. Okay. For the rest of you, coffee's in there. It's probably worth going now before it stews too much. Right. We are way ahead of time, so I can talk for hours. I'm not going to, though. What we're going to do is talk a bit about paediatric foot and ankle. And whenever we talk about paediatric things, you've got to have pictures of shiny people in sand and everyone looking happy. Okay, we're going to talk a little bit about the normal development of the foot. We're going to talk about assessment. We're going to talk about some paediatric conditions and some treatment options. And a disclaimer here, some of these people have been treated without frames, and I apologize for that. Right, normal development. Fresh, normal feet are usually nice and flexible. They've normally got a fairly straight lateral border, but they've got a big fat pad in the medial arch here, okay? And that causes enormous distress to many people. My children have flat feet, which means they will never play rugby for Britain or wherever they come from or anything. So you must fix it, doctor. This child has flat feet, you have to do something. And trying to persuade them that I don't have to do something takes up an awful lot of my elective clinics, okay? There's no arch at birth, but it may take 3 years for that to form, that arch, okay? And the proximal alignment of the lower limbs changes as you grow, and that changes the way that your feet hit the ground. If you are varus, your feet hit the ground like this. Sorry, there's a camera, like that. Okay, if you're valgus, then they're like that. And so your feet are hitting the ground on the medial border, which makes you look more flat-footed. Yep. So we're going to talk through a bit about clinical assessment, okay? I always call my own patients into clinic, and I think that's the start of the assessment, because the children and their families don't think you're assessing them until they're in the room. But if you go out into the crowded waiting area and shout above the noise of the radio that's playing and everybody else and call the kids in, they're distracted, and you can see how they walk normally. You can see if they're tiptoe walkers, you can see if they've managed to stand up from the floor where they were sitting or anything else. So I recommend doing that. Start proximally. In the same way that when we were assessing the lower limbs with our lines all over the place, we did the joint line convergence angle first so we wouldn't forget to do it later. Start at the top and look at the spine, okay? Because they might have one of those. It's quite unlikely that they're going to be sitting in the waiting area with one of those open. I would have hoped that it would have been addressed by the time they get there. But there may be something else up there. There may be a hairy patch, there may be a dimple, there may be a big scar where they have had a spina bifida lesion closed. So start at the spine and work down. Okay. We'll have a look at the femur. We know about the W position. Okay. And we'll assess their femoral anteversion with them laying prone, as we have talked about earlier in the week. Okay. I apologize for that photograph. That was taken a long time ago. So I examined my own son wearing a watch, cufflinks, and a tie. None of those are allowed anymore. He's graduating tomorrow. We talked about knee alignment. This is the Selenius curve, which is beloved of the pediatric orthopedic examiners. Draw that curve for me. Kids are born with their knees in varus. They come straight at about 2 years. Then they go a bit knock-kneed. Then they get a bit less knock-kneed. I've had numerous referral letters. Please see this child. They were a bit bow-legged to begin with, but now they're a bit knock-kneed. Yeah? Actually, that's not an adequate response. Yeah, apparently. We'll look at the tibia as well, and we'll do that by looking at down on the foot from below. So we're looking at the thigh-foot angle. Okay, so that's the angle between the foot and the thigh to tell us about tibial torsion, but we'll look at the foot as well. And we'll do that with the heel bisector. You imagine gripping the heel, drawing a line down the middle of the heel, and that line should come out between the second and third toes in a normal foot. Okay. If there is adduction in the foot, it'll come out between the third and the fourth toes. Okay. If it comes out several inches away from the fifth toe, you've got something that you need to address probably. Okay. So for the foot and ankle part, start with Silfer-Skjold's test. Here is a diagram that I found of Silfer-Skjold's test. This is not how I do Silfer-Skjold's test. Everybody understands Silfer-Skjold test? We're looking to see if there is a difference in the tightness of the gastrocnemius and the soleus, okay? When the knee is bent, gastrocnemius is relaxed, so any limitation of dorsiflexion is just from the soleus. Okay? The other thing that can give you a false appearance that the foot is dorsiflexing is if there is movement through the midfoot. If you've got a midfoot break, if Chopin's joint is unlocked. So hold Chopin's joint locked. Hold the heel in your hand heel here, and hold that in varus with the foot resting on your forearm. And flex the knee all the way up. See how much you can dorsiflex it, and then extend the knee. And if there is differential tightness because of a short gastroc, you'll feel the foot push you down. Ask them to walk on their heels. Can they walk across the room like a penguin? That tells me if tib ant's working. It tells me if they've got reasonable ankle dorsiflexion. And can they walk on their tiptoes? Yep. Tells me if the calf works. The other thing I'm looking at when they walk on their tiptoes is the alignment of their hind foot. When standing, the heel should normally be in valgus. When they stand up on tiptoes, the heel should swing into varus, and the arch should reconstitute as well. That tells me that the subtalar joint is mobile. The other way to look at the arch, with them standing here, looks a bit flat-footed. This is my son, he is slightly flat-footed. He's not playing rugby for anybody. Maybe I should have treated him. Probably not. This is Jack's test. Dorsiflex the great toe, tighten up the plantar fascia, and because of the windlass effect, you restore the arch. If the foot is mobile, the arch will recover, and you can see the arch in here. Okay? It's a very simple test to perform. Look at the foot itself. Deep creases are bad. Deep creases are a sign of some underlying problem. You should have minor fine creases all over the place. Look at the curvature of the foot. We talked about the lateral border. And feel for bony prominences. Is there a big bump somewhere? Can you feel the talar head down here in the middle of the sole? Okay, is there a massive great lump poking out medially? And examine subtalar movement. For subtalar movement, grasp the talar neck, hold the os calcis and see if you can move it underneath. Okay, that's the way I was taught to do it. Other way to do it is to dorsiflex it so that the wider part of the talus is locked into the ankle mortise, and that stops the talus moving so you can feel if the os calcis is moving underneath that way. And look at their footprint. This is a brilliant device. This is a podoscope. This costs a few £100. It's an awful lot cheaper than a gait lab. Stand the child on the top, turn the lights on, and you can see their arch. Okay? Lots of children look flat-footed, but when they stand on this, they've got a reasonable arch. And that reassures the parents amazingly well. And they say, so I don't have to go and spend a fortune on start-right shoes, doctor. No. You can see this is a green light. This is great in Glasgow. We've got 2 football teams. Rangers are blue, Celtic are green. So you stand the child on the box and you say, oh, let's see which football team you support. And you turn it on, and half of them are absolutely delighted, and the other half, the parents say, get off that, no. So let's think about some foot conditions. Any questions about the assessment so far? Nope. Okay, clubfoot is a classic. Okay. There are many components to clubfoot. There's cavus. Okay. We've got an increased arch here. There is equinus, because it's pointing down the way like a horse's foot. There is varus in the hind foot. And there's adduction of the forefoot relative to the hind foot. Okay. The best way to assess this, I think, is with a Pirani score. The Pirani score is this simple score. 6 components, but it's looking at each of the things that we've talked about. You've got 3 for the hind foot, 3 for the midfoot. You've got something to poke, something to move, and something to look at. Okay? So here on the midfoot, we're going to poke the talar head and see if we can feel it. You shouldn't be able to feel a talar head because it should be covered by the navicular. Okay? Something to look at is whether there is a deep crease down the middle, and something to feel is whether it comes straight. In the full corrected position, you should have a straight lateral border. Okay? In the hind foot, poke the os calcis. Can you feel the os calcis? If the os calcis is pulled up inside the heel pad, it'll feel like your chin. Okay? If it's down where it should be, it'll feel like your forehead. If you poke the child and then do this and then do that, then people think you're weird. So don't do that. Just do it beforehand. Score 0.5 if it feels like your nose. Okay. You need to see if the ankle will dorsiflex past neutral, and you need to see if there is a deep crease across the back. This deep crease is a sign that the heel is pulled up because the TA is tight. This is how you treat clubfoot. I will accept no other answer. Okay? There are lovely operations, posteromedial releases, beautiful anatomy, all kinds of things. They're horrible. Okay? It's a great, big, scarred operation which leaves you with stiff, painful feet. Ponseti's treatment gives you nice, supple, flexible feet which fit into shoes. The x-rays might not look normal, but we know from what Prof said that we don't have to worry about the x-rays. We want a nice, supple, chewable, sensate plantigrade foot. And you can get that with Ponseti management. And the way you do that is serial casting. We put a plaster on. We know that the fundamental deformity is a subluxation of the navicular off of the talar head. So we put a thumb on the talar head and we move the rest of the foot around that. And you hold the forefoot and you move that round the talar head, correcting the deformity. You do not hold the hindfoot. The hindfoot follows the midfoot round. Okay, the hindfoot will correct as you correct the forefoot. And the equinus part of it is the last part. That we deal with an Achilles tenotomy in about 80% of people. So you normally need about 5 or 6 casts. You put your thumb here, talar head, you correct the cavus by elevating the first ray, and then you swing the foot round. And what we're doing is pushing to the extremes of congruency each time, letting it rest for a week, and then pushing it a bit more so it remains congruent all the way through. The reason that the open operations are bad is that you take congruent joints and make them incongruent. As soon as you do that, things get stiff. So don't do that, do this. Okay. So the Achilles tenotomy we do in the clinic. I don't have the parents in the clinic. Of those of you who do Achilles tenotomies, just out of interest, how many of you have the parents there? Yeah. So when I was taught to do it in Sheffield, we did that, and I think that's quite good. If you think about the best horror films, they're the ones where you don't quite know what's going on and you just imagine what's going on, okay? And there's a man in that room with your child and a knife, and you're having a coffee outside. Not quite sure what's going on. But if they're there in Sheffield, I don't know if it's still the same in Sheffield, but the kids sat on the parents' lap while we did the tenotomy. I don't know if that's... Well, what we do is put a bit of Emla cream over the back, send the patients off for a coffee, and when they finish their coffee, they come back, everything's done. It's a very quick, simple, full tenotomy. You feel it go ping, the foot dorsiflexes nicely, you put it into a new plaster in this position, and you leave that cast on for 3 weeks. Once they come out of that, they go into the boots and bar, which are with boots attached to a bar that's about shoulder width apart, externally rotated 70 degrees on the corrected side, 30 on the uncorrected side. And they wear this for 3 months for 23 hours a day. So they can take it off for a bath, and then they wear it nights and naps until they're 5 years old. You can get great things that wrap over here called bar bumpers that you can have embroidered with their name, or it's a snowboarder in training or something cool like that. Okay, and our hospital charity actually provides those for everybody now, which is a nice way of getting the families on board with their treatment. You don't have to buy these expensive ones. You can get a couple of tin cans and attach them to a stick if you want. Doesn't matter, but the principles are exactly the same. Okay, and Ponseti treatment is wonderful. The things to look out for are the atypical clubfoot, where you've got a short first ray and you've got a deep crease all the way across the midfoot. The problem with these is they're very tight posteriorly, and so you have to modify the casting technique and stretch out across the whole sole of the foot first. You may also have to consider an early tenotomy so you can unlock the hindfoot so that the oscalters can swing underneath the talus. Sorry. Ponseti is not a non-surgical technique. Okay, 40% of patients will need a tibialis anterior transfer when they are about 3 or 4 years old. All the calf musculature is weak. They're weak on the lateral side, and so the tib ant tends to overpower, and they have dynamic supination. As they walk, the foot supinates. And you can see that in clinic. You wouldn't normally expect a foot to be quite as supinated as that at the time that you're coming in to do an operation. If they're that tight, then you probably want to do some serial casting to try and improve their foot position before you consider doing a tendon transfer. But it's 2-incision technique, full transfer of the tibialis anterior from the medial cuneiform to the lateral cuneiform, which will give them good dorsiflexion, but pull them in the right position. Yep. So what do we do if the foot comes back, if it recurs? So I would like to emphasize that that dynamic supination is not a failure of Ponseti. That is part of the management. 40% will need that tib ant transfer. But if the foot has come back again when they're 6 or 7 years old, we've got the same principles of treatment. We want to try and improve that foot position. We want to restore bony alignment, balance the soft tissues, plantigrade sensate foot, all of those things that we do for any foot. So you can try casting again. It's not going to do any harm to try a few weeks of casting. It's not going to do any harm to do an Achilles tenotomy again. Okay. Think about the tib ant transfers if they've not had one of those. But if they are under the age of 8, then you may be able to consider some kind of distraction of soft tissues, which might encourage more bony growth. If they're over the age of 8, you're probably going to have to do something bony. So here's one. If we look at her, she has equinus. Okay, let's put the tibia pointing upwards.
We want the heel down there and the forefoot up there so that it's plantigrade. So we put a frame on and we'll do an os calcis osteotomy, bring that down, wait for that to fill up with bone, and then we'll do a midfoot osteotomy. Bring that up, wait for that to fill up. And then we have a picture like that, which is a perfect picture because you can't see what's going on at all because there's metalwork everywhere, okay? But it's aligned roughly in the right position. That's 90 degrees. Yep. I love toe wires. I particularly love taking toe wires out when there's a student in theatre because it freaks them all out. Right. Toe wires are great. You can try sloops under the toes and all kinds of other things to help keep the toes up. You can tell the family that they have to do regular stretching. They never do. If you put the leather toe wire things underneath, the leather toe sloops underneath, the toes just end up curled tight with a big leather thing digging into their toes here. Put the toe wires down, spread the toes out, and it holds your foot in a lovely position and stretches all the toe flexors while you're doing that. I've also never had a patient in one of these have athlete's foot. This is the standard Alizaroff frame. You've seen the hexapod treatments for frames, but the standard Alizaroff frame is very nice and it's very customizable. Okay, it's simple. You can make it for small feet, you can make it for big feet. You've got an attachment to the tibia, you've got a half ring around the hind foot, and you have 3 motors for the hind foot. So you can lengthen all 3 motors to push the heel down. You can do differential lengthening for correcting to varus, to valgus, or whatever. You've then got a motor from the lateral side to the forefoot ring and one from the medial side to the forefoot ring, so you can correct your adduction or abduction. Okay. And you have pronator and supinator motors here. You can pull on both of them to lift the foot up out of midfoot plantaris, or you can do differential to correct rotation in there. Under the age of 8, you don't necessarily need to be doing osteotomies. You can put soft tissue distraction across here, and that distraction and unloading the bones will sometimes encourage a bit of extra bone new growth to correct the deformity within, the same as putting a hinged distractor on a hip or something else. If you want to play with talar spatial frames, then this is a good picture. This is a QR code. You may have seen some of these earlier in the course. So the Baltimore group developed the Ponce-Taylor frame. It's an excellent paper, lots of diagrams, and they use a 2-ring talar spatial frame. Okay. In these first ones, we have a wire here through the talus connected to the top ring, and they use the ring to swing the hind foot round underneath, okay, and correct the hind foot position. Then they put that talar wire attached to the distal ring and go on and correct the ankle equinus. And then finally, you take a saw to the ring and put some motors in here, and that does the same as those medial and lateral plantar motors that I showed on the standard Alizaroff device. Once you've done all that, you've got to think about what to do with the foot afterwards. If you've done soft tissue distraction, there's a high risk of recurrence, so I'd always recommend overcorrecting with that because there will be some rebound. So keep the frame on for at least 6 weeks before you take it off, but I'd think about a splint, an ankle foot orthosis, or something else to help maintain your correction afterwards. Okay? This child has not got clubfoot, but they've got a foot that looks clubfoot shaped. And this is one of the first patients I inherited as a consultant. She'd had 2 previous posteromedial releases and distal tibial derotation osteotomy, that you can see here. And she's got 1, 2, 3, 4 toes. That's part of the assessment, count the toes for every patient that you see with pediatric things. She was listed for a redo soft tissue release. When I tapped her scar, it sounded like this. So I didn't think that I could necessarily go through it again. I asked the plastic surgeons, and well, when I got them back from the private sector, and they said no. So we did a frame, and we did a soft tissue distraction for her, exactly the same kind of frame, same motor, and it improved it sufficiently, spoiler alert, improved it sufficiently that we got her into a plantigrade kind of position and get a splint back onto her. And then I sequentially took more of her toes off over the next few years. Okay, the opposite of clubfoot, then, I'm going over, sorry. The opposite of the clubfoot is the congenital vertical talus. This foot has a rocker bottom, okay? You can feel in the sole of the foot the talar head. There is dislocation of the talonavicular joint. And I'd get some radiographs for this one, and on this you saw all the angles that my colleagues talked about before. Here is the talus, and here's the first ray. That's not right. Okay. Now, flexible flat foot will have an angle a little bit like that, and you want to make sure this isn't a flexible flat foot, so you do a forced plantar flexion view, and you can see that the talus is still pointing down the way relative to that. If everything corrects when you do a forced plantar flexion view, that's a flexible foot and probably doesn't need the same treatment as one of these. For these, you do Ponseti, but the other way around. And you'd aim to bring the forefoot around to meet up with the talus. Once you got to that position, you probably need to think about something surgical, and it's an a la carte thing that for all of these foot things in kids, you do as little as is necessary to stabilize it and keep it there. So you probably will need to lengthen your tender Achilles. You may well need to open that tailundivicular joint if it hasn't reduced and maybe pass a wire across it. If it's a really difficult deformity, then some people would think about transferring the tibialis anterior to the talar neck to lift that talus up relative to the navicular. And the abductors and the extensors on the lateral side are often tight, so they may need released. Now that's different to the calcaneovalgus foot, which looks similar, but which you'll see referred quite often. And this is just a molding deformity. Anecdotally, all of the mothers of these say, I had this terrible pain up here for the last 3 weeks of pregnancy. And I think that's where the foot is jammed up underneath their ribs while the head is engaging. So these correct and can be stretched out by the family after they've had a bath. They can do a massage, whatever else they want to do, and they usually get better. But a child who's got a foot like that has been molded because it's a big baby in a small bag. So check that they haven't got DDH, torticollis, or other things as well. That is not a calcaneovalgus foot. That is a posteromedial bow of the tibia. And the deformity here is in the tibia. So always be aware of the difference between the two. If you look at this, you can see that there is a curve here. And the radiographs here show the apex posterior and apex medial. So a posteromedial bow, which is changing the shape of the foot position. And most of these improve with growth, but they tend not to improve fully, and there's usually a leg length discrepancy that might require intervention later on. So we've got a posteromedial bow. This is an anterolateral bow. Okay. Good 50% of these are associated with neurofibromatosis type 1, so look for these. Look for cafe au lait patches, look for leash nodules, or a family history or anything else. So I'll just cover treatment of pseudoarthrosis of the tibia in the next minute. No, I won't. It's a nightmare. Treatment of pseudoarthrosis of the tibia. Okay, if you want to talk about that later on, then we can do that if anybody's got a couple of days free. I've got 3 on my list to do at the moment, so I can tell you next year. There are lots of different reconstructive options. You can pop a rod up, you can move bone around, you can do vascular stuff. We're not going to talk about that, too much to talk about, and I've already overrun. So thank you to Hemant and the others for being quicker. Okay. That is not a posteromedial bow or an anterolateral bow. This is an anteromedial bow. This turned up in the clubfoot clinic for my colleagues who came and knocked on my door and said, Dave, I don't think this is a normal clubfoot. It's not a normal clubfoot, okay? Here we have fused first and second toes. We've got this dimple thing, and this dimple is a dimple that you see over the apex of deformities and congenital lower limb deficiencies, whether it be a femoral deficiency over at the side, whether it be a fibula hemimelia over the apex of the deformity in the tibia, or elsewhere. It's not a surgical thing. There's a leg length discrepancy here. In fibula hemimelia, the foot and ankle can be involved variably. You may have missing rays, there may be coalitions, there may be syndactyles, as you can see under here. And the ankle may be deformed as well. So this is a fairly fresh child. A radiograph at this age isn't going to be particularly helpful. We did one anyway, it didn't show us much. So the next useful thing was this. This is a feed and sleep MRI. So the families keep the kid awake, give them shake them, or not, no, don't shake children, that's a bad thing. Edit that bit out. But you keep them awake until you bring them to the hospital at night time and they just fall asleep and they get a vial of sugar or something before they fall asleep and get a quick MR. You can see on this MR that there is a tibia here. It's a bit bent, but the talus and the os calcis look weird. There's something funny here. There is an abnormal coalition of the talus and the os calcis. The os calcis is sitting alongside the talus. Okay, here's another one. Oh, it's not projected very well, sorry. Let's try that. On this one, you can see we have an anterior bow. We've got the os calcis sitting along at the side, and we've got equinus in that foot. Reconstructive options here need a fair while to chat through, okay? You need to talk about whether you can preserve that foot or not. We want, at the end of any treatment, a sensate, plantigrade, soft tissue balanced foot, okay, and a reasonable leg length. It might be that you can't achieve that. Okay, if it really doesn't look as though you're going to be able to achieve that, then an ablative procedure may be the better thing. An ablative procedure is one operation that deals with everything. If you've got good prosthetic control, it's good. I know that's very different in different parts of the world, and in some parts of the world, an amputation is really nothing that will be considered, but in some parts, amputation is the best way to go. But if you've got a sensate foot, then we're going to try and restore that sensate foot. There are loads of classification systems. I'm not going to go through all the classification systems. Super ankle is just a term for a constellation, that's a good word, of procedures that you can use around this. So the Anlage is an analog of the fibula. It's a tight fibrous band that runs down from the fibula towards the hindfoot, and it may be continuous with the os calcis and the tibia. You need to resect that usually so you can improve the position of the foot. And while you're there, do an arthrogram, and that will show you where the ankle joint is. And this ankle joint is actually reasonably well aligned in that plane. Okay? So we're going to excise the Anlage, and we are going to realign the foot and ankle underneath. It may be that you need to do an osteotomy through where the subtalar joint should be so you can swing the os calcis underneath the talus and then stick a couple of wires up it. This is about as expensive an implant as we use in the children's hospital. Okay. There are other types of fibular hemimelia where you may not have such an absence of the fibula. You might have a dynamic valgus in the hindfoot, and that's where the short procedure, the shortening osteotomy realignment distal tibia. If you want to know how to do that, there's the paper. That's a very good paper to talk about all of the reconstruction for fibular hemimelia. So that same patient who had had the treatment I showed in the past has a reasonable talus on top of an os calcis here. That's not a proper subtalar joint, but it's sort of aligned properly. Here he is going through his lengthening later on with a talus spatial frame. And I've included the heel because the Achilles is usually fairly tight and we want to try and stretch that out. Anytime I have not included the heel, I have regretted it because they all end up in equinus. And it's difficult to stretch it out afterwards. This is tibial hemimelia. Tibial hemimelia, there's no tibia. Okay, how can we reconstruct that? We saw Professor Hosny, a wonderful case where he moved the fibula across to tibialize it. It really depends whether there is an active extensor mechanism. If you've got no extensor mechanism in that knee and you have no functioning knee joint, there's nothing here up in that proximal tibia, and the feed and sleep MRI is useful for this as well, then ablative surgery is probably going to be best here. And that's what I'm planning for this patient when they're a year old. Anaesthetists don't like taking children to theatre until they're a year old, which is pretty reasonable. So we'll do that later. Nearly there. I've talked for a very long time, I apologise. Tiptoe walkers. Tiptoe walkers fill up our plaster room clinics, okay? You've got to do something, he walks on his tiptoes, or she walks on her tiptoes, or anything else. What we don't want to miss with a tiptoe walker is somebody with cerebral palsy or somebody with Duchenne's muscular dystrophy or anything else, okay? An awful lot of kids walk on their tiptoes. As they go through growth, they grow. And as they grow, the soleus stretches out because it's attached to the tibia, and the tibia stretches it out. But the gastroc doesn't stretch out so much because there are joints between everything. So they end up on their tiptoes. And then they eat more, or certainly in Glasgow, and they get heavier, and that weight stretches their gastroc out again. So examine them, watch them walk in from the clinic. As they walk in from the clinic, are they actually walking with their heels on the ground, or are they walking on tiptoes? Okay. Look at their neurology. Is the tone all right? Is it unilateral tiptoe walking? I had one patient who was treated for unilateral tiptoe walking for 2 years before she turned up to me, and it was a dislocated hip that was actually the reason she was walking on tiptoes. So don't forget to examine everything from the top down to the bottom. Gower's sign is the thing for looking for Duchenne's, where you get them to sit cross-legged on the floor, and you sit opposite them cross-legged and tell them you're going to have a race who can stand up quickest, and you see how quickly they can stand up. Somebody with proximal weakness will get up off of the floor by using their upper limbs to help lift them up because of the proximal weakness here. You need to pick up Duchenne's quickly. Okay. Silver-scale test will tell you if it's gastroc tightness or Achilles tightness. The Children's Orthopaedic Society, the British Children's Orthopaedic Society, have come up with a consensus statement. This is the opinion of all paediatric orthopaedic surgeons in Britain, largely, about how we should manage these. It's quite a useful flowchart to go through things. What you want to do is physiotherapy, perhaps, or just simple stretching. And you've got to teach them how to stretch their calves. If you say stretch your calves like a runner does, then they'll go, what's a runner? And then they'll all stand like this, and they will externally rotate their leg at the back. If you stretch your calf with your foot externally rotated at the side, you're not stretching your calf. Your toes have to point forwards, and you have to push down until it hurts. and then hold it and stretch it. Serial casting is helpful, probably in the under 12s, I would say, under 10, under 12. If you're going to put a serial cast on, put the cast on the same way that you do your Silver scales test, so you're locking Chopard's joint. So you're not pushing up and inducing a midfoot break on that plaster. So plaster of Paris, mold it, bring the foot up, and then put a layer of plastic or fiberglass, or whatever you like, over the top so it's strong enough for them to walk on. The first couple of casts may need a little wedge underneath to give them a heel so they can walk on that cast. Because if you are in a tight Aquinas in a plaster, you're just going to walk like this and fall over, and then you just won't do it. If you are going to do a calf release, then do Silver scales test carefully to make sure whether you need to release the gastrocnemius or just the Achilles tendon. And rather than release, think about lengthening. But if there is a difference in Silver scale test, you've got to address the gastroc first, do the gastroc first, and then come down to the Achilles tendon. And I do my Achilles lengthenings with a hokey lengthening. Really need to do a full open tender Achilles lengthening. Just these 50% cuts, 2 on the medial side, 1 on the lateral, give it a stretch. Wonderful. If you do that and it goes ping, you're going to put them in plaster anyway, and it'll probably heal up all right. So in the next minute, we'll just talk about cave-varus feet. Cave-varus feet are neurological until proven otherwise. That's the take home from here. We've talked about cave-varus feet already. Prof talked through one of those. Careful assessment of the neurology. Is the spine all right? Get an MRI of their spine. Prof talked about the Coleman block test. Okay, in these feet, the first ray is down because you have a weak tibant. So you're using EHL to dorsiflex the great toe so you can then use that to lift up your forefoot. But when you dorsiflex the EHL, you are performing a Jack's test, which tightens up your arch. Okay, so the first ray is down, and as the first ray hits the ground all the way down, it pushes your heel across into varus. Coleman's block test will tell you whether that corrects. So you allow space for the first ray to drop, and if the heel comes out to the side, then the heel will improve if you address the midfoot. You don't have to address the heel. If it doesn't improve, you're going to have to do bony correction at the back. Correction of the cave-varus foot is an a la carte approach. You might want to do the Jones transfer that we talked about before, where you take off EHL, bring that more proximally on the medial side so it elevates the first ray. You may want to do a tib post transfer. If tibant is weak, then take tib post off, route it round the back through the interosseous membrane into the lateral cuneiform. A peroneus longus to brevis transfer also gives you increased eversion power. You might need a plantar fascia release, you might need Achilles lengthening. And a dorsiflexion osteotomy of the first ray is probably necessary. If they're stiff at the back, then a heel shift is a useful thing. Nearly finished. The last one to talk about, and just as a quick reminder, is tarsal coalition. Stiff, painful, flat feet might have a coalition. Here is an abnormal fusion between these two bones, and that's because of a failure of separation during development of this foot. Okay? If you see one of those, look for another one. There are frequently multiple coalitions inside the foot. This is the calcaneonavicular bar classic, but there could be a talocalcaneal or a talonavicular, so get a CT first. Consider a period of immobilization for these. Okay, these tend to be painless until they start to come through puberty because it's initially been a fibrous band that then starts to ossify. And as it starts to ossify, it becomes painful because you're trying to bend something that's stiffer than the previous fibrous coalition. If you put it on a plaster long enough, it'll ossify completely and then it won't move at all and the pain goes away. If you've got time in the clinic and you're interested in doing it, ask the parents to take their shoes off because you'll find that quite a few of the parents have a tarsal coalition they didn't know about as well. Once you've excluded all that, go in, chop it out. No metal, no plaster. Okay, so, sorry that's gone on quite a long time. The summary here is that you need careful assessment to work out exactly what it is you're dealing with. The principles of treatment are exactly the same. You want a nice, supple, chewable, plantigrade sensate foot. If something's flexible, you can probably get away with some kind of soft tissue management for it. If it's stiff, you're probably going to have to do something bony. But where possible, try and preserve the joint congruency. Children are not small adults. Okay, you have to say that. It's an obligatory thing if you're a pediatric orthopedic surgeon. You have to say that phrase. Okay, that you won't be able to fit big rings around small feet, so you may have to think about changing it. But some of the newer hexapods with their step-off plates can be adjusted for pediatric practice. Okay, any questions on anything there?
For the Hoke procedure, do you do a medial, 2 medial and lateral regardless of the hind
Usually
foot?
if it's in varus, the hind foot, then 2 medial, 1 lateral.
Okay. That's if it's in varus.
If it's in valgus, then I would maybe consider doing it the other way around.
All right.
So put the 2 on the side where it's tightest.
Yeah, thank you.
Nick's got a question
Next
here.
question. Cheers.
Talking about hidden deformities, I wondered about your experience. For some of the severe toe walkers, I find some of them have hidden external tibial torsion. And so I discovered that post-release for my first patient some years ago, and they were quite disappointed to find their feet pointed out significantly externally. Now I look for it clinically, and I sometimes check with the rotational profile, and I talk to them about the option of doing both at the same time. Okay. Is that your experience, or do you... Or
I can't think of any off the top of my head where I've had to go and do a derotation afterwards, but you're absolutely right. It's something to look for beforehand. Always, if you go through that process of assessing everybody from spine, rotation, I assess a rotational profile in nearly everybody, apart from the radial club hands or others. But I don't think you're going to, it takes a couple of minutes to do a rotational profile. And the thing that everybody learns when they come to peds is do it prone. And if you just flip the kid over onto the belly, you can do a rotational profile in a couple of minutes. And it's an easy part of the assessment, and it just gives you that extra piece of information that might give you a clue as to something that's going to come up later on. The difficulty with doing the rotational profile for the tibia when they've got toe walking, if they're really tight in their tendo Achilles, then you can't look at their foot properly to do the thigh-foot angle. So you have to modify it a little bit. Do you have a particular way that you like to do that? So looking at the transmalleolar axis rather than the thigh-foot angle.
Get a rotational profile CT just to see, to quantify the deformity. So at least we know about it, even if we're not going to correct it.
Yeah. In general terms, if you're thinking about doing something soft tissue, you should probably make sure that the bony alignment is right. There's no point doing a tib-ant transfer if you're going to do a massive rotation of the distal tibia as well, because you'll change the tension of that tendon transfer.
Scott, question, comment?
Salenius Wonka curve.
Yeah.
That is only good for Caucasians. Those who work in multicultural society should look up. There's a good study from Nigeria about how the African kids go through this, completely different. And there's one study from Chinese, and it's again completely different. It doesn't look anything like Salenius Wonka. So those who work in multicultural society should look at those studies. It's completely different.
Okay. Thank you. Good point. Thank you.
So in a pediatric flat foot, what's your cutoff point of doing like a flat foot in a child? I mean the age, because when the parent comes to you and asks you, you keep reassuring the parent that this will resolve and you have to follow
Pediatric flat foot. Sorry,
pediatric flexible flat foot.
Flexible flat foot, I would aim to do as much nothing as possible for a flexible flat foot.
And the other part of the question would be, what's your surgical option for the flexible flat foot?
My surgical option is to do as much nothing as possible until they're about 16 years old and then send them to an adult surgeon. I really try very hard not to do anything. If they're really, really pushy, then I'll send them to orthotics for an insole. But I hate insoles of flat feet. They don't make any difference. Okay, I have flat feet. I have insoles in my cycling shoes. It increases the power through my pedals when I have insoles in. So I think there are places for insoles, but I don't think that there is. Everybody familiar with Mumsnet and other online discussion forums or things like that, where children are referred to as DD and DS, darling daughter and darling son, and it's all about which kind of gardener you should get or which is the best hummus or anything like that. Okay. But there are full of things going, oh, those children have flat feet, they'll never be any good at sports. They must have insoles, they must have that. And so people come into the clinic and go, I want these. And it's very hard to tell them you don't need those. But there are loads of studies out there to show that you don't need those. Buskos is doing another consensus statement for flat feet. I don't think it's quite published yet, has it? But there is another one coming through.
There was another question there, yeah.
Yes. In the first case, clubfoot, which treated with a frame. Could we consider treatment with supramalleolar osteotomy?
Well, if you do a supramalleolar osteotomy, if the alignment of the talus, if the alignment of the tibia is normal, if they've got a normal ADTA for the tibia, and you do a supramalleolar osteotomy and tip it like that, then you're going to introduce shear. Gavin's coming at exactly the right time because this is one of his popular things. We're asking about whether a supramalleolar osteotomy would work for somebody with residual equinus in clubfoot. Could you just go and do a supramalleolar osteotomy? But I'm saying that if you do that and reduce the ADTA, you introduce shear and you increase the risk of later osteoarthritic change. Would you agree?
Yes, I agree. And if you're doing supramalleolar osteotomy, don't forget that it's not at the core So you always have to induce a translation, whether it's medial lateral. Otherwise, you get a foot that's pointing forward. It's a bit like trying to walk with a snow ski. You can't go over your foot, your foot's now too long. But there's a limit to what you can do with supramalleolar osteotomy because, particularly in this case, as you say, the shear effect, which is not protected the joint, cartilage doesn't like shear, it'll fail early osteoarthritis, and you get the ankle starting to sublux forward. So there's a limit to what you can do in equinus correction with the supramalleolar osteotomy.